Good morning to everyone and welcome to my YouTube channel again. A small gap has come. So we will go to neonatal resuscitation today. My channel is Pain-Free Partha and my slides are all freely downloadable in www.painfreepartha.com. What is the actual need neonatal resuscitation? Approximately 10% of the newborns only require some assistance. Okay. And out of which only 1% require extensive resuscitative measures. And out of which 60% can be predicted antepartum. Okay, this is going to be a problematic child. I know, I'm ready with things. All these things, 60% can be predicted antepartum. The need is continuous. So there are certain queries we need to ask the obstetrician. Usually the pediatrician will ask. And in some centers, the pediatrician, some problem is there, he comes or she comes a little late. And we need to tell everything. Now, what are the initial queries? Gestational age, multiple or single, meconium staining or not? Is there any maternal diseases or is there any fetal distress? So, main gestational age is very important, and fetal distress along with maternal diseases. For example, maternal diabetes, maternal thyroid, all these things we should ask before going to set up a neonatal resuscitation. How to be ready? You have to pre-warm the clothes. Actually, we can have 3 layers and in the manual mode. Manual mode means it will go on giving warm air. Warm air. So there is no control. Goes on like. So manual mode we have to keep for warming the clothes. We have to keep the equipment ready. For example, laryngoscope with a different blade, a kidney tray, size 2.53 size tubes, an infant resuscitator, a bulb syringe, so many disposed syringes, normal saline dextrose, cannula, jelly, plaster, gloves, umbilical cord, everything we should be ready. And other than this, it is preferable to have one LMA size 2 or 1.5 or 1. And it is not preferable to use this. Then the next set is oxygen is ready, circuit is ready, and the weighing machine is ready. We need to have manpower, temperature, airway, breathing, oxygen, N1 liters. Okay. Airway should be there. We should breathe, or the patient should breathe. Oxygen comes very late, and drugs comes next. Sometimes we need to have this also. Respiratory equipment, oxygen supply, yes, fantastic. Assorted mask. We should not have only one mask. We should have some one Randall Baker, one normal, everything, so that it is easy to have exchange if there is any problem. Neonatal bag and tubing, a manometer, endotracheal tubes 2.5, tape and scissors, laryngoscopes, and preferably two, and bulb, battery, etc. Stillets, CO2 detectors, capnographs, pulse oximeter. Laryngeal mask airway is now coming up because I have used a lot of LMEs in PP, in neonatal resuscitations. Intravenous catheters 24 or 22, sterile dressing, dextrose, saline, and all these syringes. You can have, yes, test tubes, sterile procedure tubes, that is coming the next advanced procedures. Umbilical artery catheters, umbilical catheters. Usually one neonate means one trained person and one untrained person, at least. If you have twins, 2 trained persons and 2 untrained, or preferably 2 trained persons, definite. And theater can be walk. For example, theater is around 20 degrees normally. You can warm it to 26, 27 like that. If the baby is crying, breathing, active, you don't do anything. Should not be separated from the mother and should not be dried, placed skin to skin with the mother, covered with the dry linen and maintain temperature. Observation of breathing, activity, color, and ongoing. Sometimes after the normal delivery, they'll just put it like this on the lap of the mother, skin to skin contact, and starts breastfeeding. Every birth attendant dry, warm, stimulate. DWS is the essence of the talk today. DWS, dry, warm, stimulate. Dry, warm, stimulate. For vigorous term babies, delayed cord clamping. 30 seconds later we can clamp. Normal, term, vigorous. Non-vigorous, we just take the baby and milk the cord. So we should be careful. These are all the things for normal babies or some abnormal. They don't have multiple cardiac anomalies or something like that. Inflation and ventilation of the lungs are a priority in newly newborn. Just ventilate the lungs if there is any problem. So what is the essence? Dry, warm, stimulate. Vigorous, delayed cord clamping. Non-vigorous, milking the cord. Some people don't practice routinely DCC. Now I have a novel site of tactile stimulation, my site for neonatal resuscitation. This is the site you can see. I don't stimulate the back or the tip of the thing or anything like that, but I will do this. This I won't do. Now
You
I
are
see
ready?
bilateral inguinal region. Just immediately the baby will cry. This is my site of. Now if there is some problem, cut the cord and shift to radiant warmer. Servo controlled, yes. Now your manual controlled your machine is. Pediatric neonatal machine is. It will be warming. Now what you have to attach a probe in the patient's in the neonatal body and then connect it. So it should be servo control for 36 days. Don't boil the baby. Okay. No manual control after the delivery. So already we have pre-warmed clothes. In 10 seconds or something, to take out this thing and one more linen. So remove the linen. That is what is called dry. Just dry it and remove the linen. And we have already 3 layers. So warm, clear airway, dry stimulate. Heart rate below 100. Something is wrong. Heart rate is below 100. Then you start your PPV. Okay. Start your PPV. PPV comes to mind, ventilation, heart rate picks up. Then leave out. If the heart rate doesn't pick up, continue ventilation for some time. And if the heart rate is below 60, then start CPR and think about ventilation, intubation. That is what is the 2 things which we should remember. 100 below is PPV, 60 below is maybe CPR and chest compression. Routine care, warmth, clear airway, dry, and ongoing evaluation is a must. Continue. Dry change linen secretions. Sometimes what you do is you just push in the bag where a bulb syringe is there, no suction. That you put in the nose and you also put it to touch the nasopharynx. It will increase the stimulation. So just turn the baby, make it slide head down, then orally suction the buccal mucosa. That is enough. Don't stimulate the nasopharynx much. It will cause bradycardia. So don't touch the pharynx. Dry stimulate and stimulate fixer. I have got my own place to stimulate. 40 to 60 per minute. Now you should breathe, tuck, 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 and breathe. Not and some people do slowly like this, but I usually do as around 30 to 40 minimum. Room air is enough. Room air is enough for positive pressure ventilation. No chest rise, then you see mask seal, his position is okay. If you want to put an airway, preferably go for a laryngeal mask airway. Heart rate picks up, stop PPV. If the heart rate doesn't, continue 1 more minute. Less than 60, start chest compression. Take ventilation corrective steps. So targeted approximately 60 minutes. Golden minute are allotted for completing the evaluation and beginning ventilation. So you go on waiting for so many seconds. That is why I told vigorous babies delayed cord clamping. That is 30 seconds. Non-vigorous babies, non-term babies, you should take the baby with us and maximum because Swiss umbilical cord. Observational care or resuscitation care. PPV more than 1 minute. Yes, we need resuscitation care. More than 2 minutes, then the baby is picked up fine. If you are ventilated for more than 2-3 minutes, then put nasogastric tube and remove this. Or a orogastric tube and remove the air from the stomach. You need to watch 20 minutes. Everything is fine, then shift. Other sick babies go to NICU. Consider intubation chest compression, heart rate below 60. Consider hypovolemia and pneumothorax. Give some 7 or 8 ml per kg of normal saline. If you do it blood sugar, you think if the hypoglycemia is the cause, then give some dextrose. Stop chest compressions if heart rate is above 60. Stop PPV if heart rate is 100. So 60 and 100 are the benchmark heart rates. So don't try to check so much. Yes, we can put pulse oximeter. Meconium Steinleicher, vigorous babies, muscle tone. Non-vigorous babies, previously they told, do a suction and trachea, meconium aspiration. Vigorous muscle, don't do much. Heart rate is 100, breathing is normal, do a oral suction and just keep everything normal. The babies know how to remove the meconium. Meconium aspiration, if you are not able to intubate, if there is any problem, leave it alone, do a PPV. Don't try to took the tube at all. So, non-vigorous babies also ventilate rather than intubate. But heart rate is less than 60, still the color of the baby and saturation. Then we can put the tube, start the oxygen, and then give through the tube adrenaline. Plan for UV catheter and intravenous adrenaline. And also we can use, because hypovolemia and chest pneumothorax may be a problem. So give saline. 10 ml per kg over a period of 5 to 10 minutes. If you have an abrasion, think of O-negative RBCs. The saline can be repeated even 3 to 4 times. You just wait for some time, 2-3 minutes, and then give one more shot of saline. Continue resuscitation, talk with parents, talk with NICU team, shift the transport incubator if distance. Continue resuscitation, talk with parents, talk with NICU team. In summary, on temperature control, dry and keep warm. Pre-warm the delivery tube. You just covering of plastic wrapping. Exothermic mattress. The baby under the heat, but it is going into servo control. And that means after the baby's temperature goes to 36 or plus, the warming will stop automatically. Normothermia and avoid hypothermia. Unheated, non-humidified oxygen sources can be there. Intubated, ventilated patients, humidified, warmed ventilator circuits. Now we can see here many times temperature range. I'll go to oxygen later. This is what we should aim to. 36 is fine. 36 is fine. 32 to 36 is slightly you should take care. Less than 32, 28, 29, the outlook is great. So keep it around 36 or around 35, 36. Oxyhemoglobin saturation may normally be 70 to 80% range for several minutes. So don't try to make it as 100, 99. It is normally 2-3 minutes, it's around 80, 85 only. Clinical assessment is a poor indicator, so color may not be good. 100% oxygen you don't give. Intubated patients, ventilated patients on CPR, you need to give oxygen. Around 30% is enough. So PPV, no intubation, no chest compression. 21% oxygen is enough in PPV. Back mask ventilation, positive pressure ventilation. Intubation during chest compression, oxygen. Yes, that even in is less than 35 weeks is 21 to 30% oxygen. See here, normal is around 60 to 65, it goes up to 70 to 75, and 10 minutes around 90. Don't try to reach around 100. A preductal is right upper extremity, right upper lip. Very important to have saturation. Term infants around 90. Preterm around 85 to 90. Monitor the progress. CPAP machine to infants who are breathing spontaneously 4 to 6 centimeters, followed by those been studied in infants born preterm also. Yes, we can use CPAP to infants breathing spontaneously but not maintaining gases. So here you can see here, birth rate 30 seconds we have to decide. 60 seconds PPV SpO2 monitoring. Heart rate below 100 start, continue PPV. So this is the golden minute. Yes, start your dry warm, stimulate and remove adrenaline, dry, clear, warmth, and start PPV with pulse oximeter monitoring. Again, I'm telling preductal is only 60 to 65%. 30 seconds and 60 seconds. Laryngeal mask airway that fit over the laryngeal inlet, yes, affecting, but maybe more than 2 grams and delivered around 34 weeks. It's very difficult to ventilate with LMA, very preterm patients. Initial endotracheal sectioning of non-vigorous MSL gone. Bag ventilation is ineffective or prolonged only. Special resuscitation circumstances, congenital diaphragmatic hernia, extreme low birth weight, we are not bothered now. In a newly born baby with no detectable heart rate for approximately 10 minutes, nothing is there, completely no movement, nothing, heart rate is not there for 10 minutes, we can stop. What is shocking is there is no Apgar score. Apgar score is summing up the 5 values. 5 criteria is appearance, pulse, grimace, activity, and respiration. Grimace is some movement on stimulation, active movement on stimulation. Now the appearance is red, periphery is blue, total width ultra, pulse 100, respiration absent, weak. This is what is the active tone, good results. Heart rate is more than 100. Yes, it is usually around 8 or 9. Good babies. Don't rate as 10. Apgar score of 10 is more than 7 is okay. 4 to 7 we need to act. Or less than 3, persistently it is there for more than 10 minutes. Yes, definitely some neuro damage is there. We can look at the anterior fontanelle, posterior fontanelle, any injuries, eyes. Yes, I usually tell when the eyes are opening in the baby, there is some problem. Eyes are usually closed in the neonates. Just think about, look for any problems. You look for any neuro damage when the eyes are permanently open. Like, look for the spines. Put an nasogastric tube, orogastric tube. See the fingers, see the nipple, see the scrotum, whether the testis has come down. To see any baby which is coughing normally active is usually a term baby. Rice tube, actually the hole is like this, but the inside hole is like this. We should keep the rice tube and go vertically like this. Keep the vertical at the tip of the nose and turn like this and go vertically. That is how the inside cavity is there. Injection vitamin K, temperature monitoring, wound oxygen is not needed. Just starts breastfeeding immediately. Feasibility of early breastfeeding after cesarean section. We have done immediately after delivery, put in the mother and it is fed. This is our article only. And even after the breastfeeding is completed, we have put a rice tube and aspirated milk in many cases. So again, 60 seconds PPV, SpVO2 monitoring. Below 100, continue ventilation, take corrective steps. And again, below 60, go for either intubation or chest compression. Again, below 60, consider hypovolemia, pneumothorax, epinephrine. Give boluses of saline and epinephrine through the tube. You should consider only 60 to 65% preductal SpO2, right upper limb, right upper limb. Even non-vigorous MSL, don't try to do. This is a newer resuscitation algorithm. Don't try to intubate and suction, can start PPV. So what are the pre-questions? Is it term? Is it meconium? Maternal diseases are there? Multiple or single pregnancy? Any fetal distress? Dry warm stimulate, DWS. Vigorous crying, active baby, nothing. Be careful. 60 and 100 are two heart values. 80 is not the correct answer. 100 below, yes. PPV 21% is okay. Oxygenation is needed only when you are intubation and CPR. Thank you very much.